Thanks, Pradeep, for the invite. I was just back there sitting and thinking there's a dearth of papers in gastroenterology over the last 1 year. There's so much in respiratory medicine, cardiology, intensive care. I think the truth is gastroenterologists are simple people. We deal with tubes open at both ends. Okay, just to keep it in a lighter vein. Of course, it may be the other way, right? Looking at Pradeep's take-home message, that sometimes we feel very confident that there's nothing much to learn. Probably we need to take a middle path. Okay, I'm going to talk on two papers. The first paper is from Lancet Gastroenterology and Hepatology earlier in the year. Early tips with covered stents. Yeah, these days tips are done with only covered stents. Uncovered stents are out. So early tips with covered stents versus standard treatment for acute variceal bleeding in patients with advanced cirrhosis. Advanced cirrhosis over here is defined as Child's B with active bleeding or Child C. So I'll just give you a background before discussing about the paper. Acute variceal bleeding in people with advanced liver cirrhosis has a poor prognosis with a high mortality at 6 weeks, ranging up to 30 to 50%. The standard of care, most of the centers that practice are using vasoactive drugs like terlipressin, octreotide, prophylactic antibiotics, early endoscopic therapy within 12 hours of the onset of bleeding, and of course organ support in the critical care department. TIPS, which is transjugular intrahepatic portosystemic shunting, done by our intervention radiologist, is used as a salvage therapy when the standard therapy fails. So there's a landmark randomized control trial that happened in the Spanish cohort by Garcia Pagan, who looked at, in 2010, looked at early tips, but in reducing the incidence of rebleeding or treatment failure of standard therapy. And that's when the concept started that early tips should be considered in people with advanced cirrhosis and acute variceal bleed. But most of the trials that have been done so far have looked at reduction in the rebleed episodes, but not on the mortality, because they were underpowered for these kind of statistical events. So the clinical question remains, in patients with cirrhosis and acute variceal GI bleeding, does early tips, which is less than 72 hours, compared to standard of care, increase the transplant-free survival or reduce the mortality, short-term mortality, which is at 6 weeks? So this was a trial which was carried out in a single tertiary center in China between 2010 to 2016. The inclusion criteria were all adults between the age of 18 to 75 with cirrhosis. They were either Child's Pugh B or C, and they had endoscopically proven acute variceal bleeding at the time of index endoscopy when they presented. The exclusion criteria were uncontrolled bleeding prior to the randomization, or they had ectopic varices or gastric varices, because these kind of people may have additional portal vein or splenic vein thrombosis which pushes the pressures up, or complete portal vein obstruction, or if there was any other contraindications to TIPS which can be seen in which can be found in any standard textbook of gastroenterology. So over the last 6 or 7 years of their study period, they screened about 373 patients. This was a single center, and many were excluded, and only 132 were randomized into the trial. The randomization was 2:1, 2 towards the intervention, that is TIPS, early TIPS, and standard of care in the ratio of 1. So 86 underwent TIPS and early TIPS, and 46 underwent standard of care. So that's the consort diagram. So what was the management that was undertaken? So all patients who had acute variceal GI bleeding, Child's B or Child C, had initial resuscitation with blood products, vasoactive drugs with octreotide, somatostatin or terlipressin, and endoscopic therapy within 12 hours after presentation. And then they were randomized to either early TIPS or standard of care. Early TIPS was performed within 72 hours, preferably within 24 hours. Vasoactive drugs were continued until the TIPS procedure was completed. Prophylactic antibiotics was given up to 5 to 7 days. The size of TIPS comes in two sizes, 8 millimeters and 10 millimeters. For all the patients in the study, they use only 8 millimeters diameter TIPS. And if portal hypertension recurred, which they had standard defined criteria, they underwent a revision TIPS or a replacement of the stent was performed. The standard of care is what most of the centers practice is continuation of vasoactive drugs, giving them propranolol on day 6 onwards, repeat endoscopy till the varices are eradicated as per the pre-specified protocol, and in case rebleeding occurred despite the standard of care, these patients underwent rescue tips. So, what were the results? So, the top left graph shows the transplantation-free survival, and all of these patients were followed up for the next 2 years for a minimum of at least 1 year. The study period for 2 years follow-up, the data was there. So you can see the red graph is the early tips patients, and the blue line is for the people who had standard of care. There's clearly the Kaplan-Meier curve widens apart as early as in the first month or the 4 to 6 weeks itself, that there is an improvement in the survival, which continues even at the end of 2 years. Coming to the right top graph, which looks at the secondary endpoints, the primary endpoint was survival at 6 weeks or transplantation-free survival. The secondary endpoints were people had rebleeding episodes. The rebleeding rates were less in the early tips when compared to the standard of care. Then the bottom left looked at worsening ascites. People who had tips did not have any worsening ascites or recurrence of ascites. Many people remained euvolumic. So TIPS has a beneficial effect of preventing ascites or decompensation of these people with ascites. However, there was no change between the two groups in terms of encephalopathy. There's always a common misconception or a common conception that people with TIPS have a higher rate of encephalopathy. Of course, if carefully selected, people who do not have previous encephalopathy episodes are the ideal candidates, and they can be considered for TIPS. So, in terms of numbers, the primary outcome was looking at death. So, early TIPS people had a mortality rate of 20% at the end of 6 weeks, whereas the standard of care 36% had. So, there was an absolute risk reduction of 16% or a hazard ratio of 0.5. So, there was a more than 50% chance that the people were alive with an early TIPS. The secondary outcomes were also statistically significant in people who had failure to control bleeding or rebleeding episodes. Early TIPS had a significantly lesser chances of rebleeding or failure to control the bleeding with a hazard ratio of 0.6. So there was a 70% reduction or an absolute reduction of 25%. Again, worsening ascites or new ascites development was seen in people who had standard of care, whereas in people with TIPS, only a small proportion of 17% actually decompensated with ascites during the follow-up period over two years. So that's the take-home message. It is a well-conducted trial which demonstrated that early TIPS was associated with a reduction in death or transplant-related mortality. And the conclusion is probably correct that early TIPS is useful for these category of patients. The limitations of this trial are it's a single center, and most of the patients included in this trial were viral hepatitis. About 80%, 76% of these people were hepatitis B and a few of hepatitis C, and the rest were autoimmune hepatitis, alcohol. So we cannot draw general conclusions that across all etiologies this can be useful. So we need to try this hypothesis in a wide variety of patients of different etiologies of cirrhosis. So, and with a greater sample size. So basically, what would my practice be, or what would my message to you guys would be? Discuss TIPS, early TIPS with all for all the patients who comes in with acute variceal bleed with child B with active cirrhosis or child C. Discuss with your GI team to see if these are the candidates for early TIPS, and you'll have to be very selective about your patients to get the best outcomes. So that's the first paper. So that leads on to my second paper, identifying who is the optimal candidate for early TIPS among the patients with cirrhosis and acute variceal bleed. This was from the same group of authors, again a Chinese study, multicentric and observational, or basically a retrospective study. So again, the background is, despite standard of treatment we've seen in the previous study, the 6 weeks mortality in people with acute variceal bleed remains significant, up to the range of 50%. In recent years, several alternative risk stratification systems have been established, such as the MELD score, the CTP score, which has been existing for a long period of time, in identifying who are the suitable candidates for TIPS, as well as other clinical parameters such as presence or absence of hepatic encephalopathy. However, this has not been systematically investigated, specifically looking at who is the right patient to be considered for early TIPS. So this was a retrospective study looking at the same question. So the clinical question is, do the effects of early TIPS on the outcome vary depending upon the patient's characteristics? So which criteria can optimize the early use of TIPS in our patients with variceal GI bleeding? So the study was a large multi-center observational study to assess the effects of early TIPS. It was a retrospective data extraction. The data was collected from 12 tertiary centers in China between December 10 to June 2016, which evaluated the impact of early TIPS versus standard therapy on outcomes, stratifying patients based on the classification. They were classified either as low risk, intermediate risk, or high risk based on the CTP or the MELD score or even the creatinine. So the low risk patients were people with Child's Pugh score A, MELD score less than 11. MELD score is a composite scoring system we take in chronic liver disease patients, which looks at their sodium, the INR, the creatinine, and other parameters, and the clotting parameters, mainly the prothrombin time. And Child's B without active bleed were considered as low risk patients. Intermediate risk patients are Child's B group or people with a MELD score of between 12 to 18. High risk were Child's Pugh with active bleeding, Child's Pugh C, or MELD score more than 19. During this period of study, more than 2,050 patients with acute variceal bleeding and cirrhosis were screened. About 1,400 patients were eligible and were included in the analysis, of which 85% underwent a standard of care, whereas about 15% underwent TIPS early TIPS as a modality of treatment for this variceal bleeding. So let's look at the outcomes, what happened based on the MELD. So if people were selected for early TIPS based on the MELD, people on the left hand, the Kaplan-Meier statistics or the mortality did not change, or the people did not have any change in mortality if you did an early TIPS for people with low MELD score. So you have to select patients with a higher MELD score. On the right hand side, MELD score of more than 19, there was a clear survival advantage in people who underwent early TIPS, which is the red graph. So basically, it's the cumulative incidence of death, what you see on the y-axis. However, when you look at the middle graph, there's an early separation of the graph in the first month. That is, at the 6 weeks, there seems to be people with MELD score of 12 to 18 have a survival advantage at early survival, but however, when followed up to a year, there was no great advantage in the survival, whether you randomize them either to early TIPS or standard of care. So the take-home message is, if someone's got a MELD score of more than 19 with an acute variceal bleed, irrespective of their child's A, B, or C, consider them for an early TIPS, because it improves the survival. So you improve the outcomes, sarcopenia, ascites, encephalopathy, and the transplant-free survival as well. Of course, you have to address the etiology of underlying chronic liver disease. If you're not considering MELD, considering only the Child's Pugh score, Child's Pugh A, whether you did TIPS or standard of care, people did well irrespective. So it's a no-brainer. You treat them with standard of care, which is cheaper. If it's Child's Pugh C, we see there's a clear survival advantage if you do an early TIPS. So that's the take-home message in the first paper that I presented. So early TIPS in people with Child's Pugh C is useful. The first paper also mentioned that there is a survival advantage in Child's Pugh B with active bleeding, but this was all comers with Child's Pugh. It doesn't differentiate. So when we look at Child's Pugh C as well, on the right hand column, there's a survival advantage. So you can even better select your patients with people with raised creatinine. People with a creatinine of more than 1 and Child's Pugh C have a better survival advantage when you consider them for early TIPS, because it's again renoprotective because of the splanchnic hemodynamic changes that you come across after putting in a TIPS, when compared with only just Child's Pugh C and creatinine being normal. How about in Child's Pugh B? In people with active bleeding, there's a clear survival advantage in early TIPS, whereas people who have bled and stopped and their child's B, standard of care is the right way forward rather than subjecting them to TIPS. So the take home message, the highest benefit of early TIPS is seen in people with child's Pew C with a creatinine of more than 1. They are the best subgroup of patients who benefit the most from early TIPS. Child's Pew B with active bleeding at the time of endoscopy. People with MELD score of more than 19. However, in people with MELD score of 12 to 18, you need to assess them on an individual case-by-case basis in discussion with your hepatologist or your GI specialist. Thank you. Happy to take some questions.